Good afternoon, everybody. Welcome to January 2023 office hours. I hope everybody's having a good day. I wanted to let everybody know that we're recording this session as always. And if you want to access that, it'll be on our website in the very near future. And as always, if you have questions along the way, feel free to unmute and ask or any comments. And we also have the chat box. So with that, we'll get started. So we got a bunch of policies that we're going to go through today as part of our review since we haven't met since last November. We have some children's updates, an update on the data den rollout network-wide, touch on comprehensive chart review audit tool. And then we're going to talk about the quality assurance and performance improvement policy that's coming in the near future, touch on PHQ-9, health home network provider update, delay reason code 3, and healthcare workforce bonus update, and then public health emergency update. So we have a pretty packed agenda today. So we'll jump right in. So policies and procedures. We're going to touch today on the complaints policy, conflict-free case management, Health Home Plus SMI and AOT, EMOD, VMOD for children, incident reporting, initiating and maintaining OPWD, LCED policy, NOD and fair hearing, outreach policy, palliative care, counseling, and support services, staffing and qualifications, and then last but not least, transfers policy. And upcoming policies as of next month will be our quality assurance and performance improvement. And as always, before we start to review these policies in the next slides coming forth, we have our link to our policy and procedure webpage, which has all of our most current policies and procedures. So just remember you have that link for a resource if needed. Jessica, are you there? We'll get you going on the first policy.
Yes, I'm here. So the first policy we have is our complaints policy. This policy was updated to include some information on children's. A lot of these policies had some HCBS children's updates. This one included. It's important that whenever we enroll a member in either adult or children's health home, that we are issuing them their rights and responsibilities and complaint procedure. We have drafted in Appendix A some documents that you can use, and you can change the letterhead to show your own internal agency. If you would like, you could use your own agency's rights and responsibilities and complaint procedure, but we do have one in Appendix A to use if you didn't want to draft your own. All complaints made to the health home will be followed up on. So that's if someone calls and leaves a complaint, or if someone issues one in writing, whether they email us or mail us something, we will respond and hopefully resolve those within 45 days. We'll respond within 72 hours, but the completion of the complaint should be done within 45 days. If we are working with the member and the CMA and we are not able to resolve the complaint within 45 days, we will reach out to the Department of Health to assist with that. It is important when working with children, and this is only children specific and children enrolled in HCBS, that if there is a complaint about Children's Health Home regarding HCBS, that complaint needs to be filed via IRAMS. That is the only subpopulation that needs to have complaints go through the IRAM system. And if you ever need help or support with that, you can always reach out to myself or the health home email. This is reviewed in the DOH 5276, which is the HCBS Freedom of Choice form for children. And there is also a FAQ that accompanies that form. This will tell the family, and you should review this with the family, how to file a complaint should they have one. Next. Next slide, you went back. Okay, there we go. Conflict-free case management, there was no annual updates, or this was an annual update, but no changes to this policy. Basically, this policy just goes over if you are a health home care management agency and you also provide home and community-based services for children, basically states that it has to be firewalls in place to ensure that if you have a member enrolled with you for health home care management, that they have the freedom and the right to choose their providers. So they have the right to choose their care management agency, their health home, and the agency that they receive services from. So if they're enrolled with you for health home care management, does not necessarily mean that they have to receive their HCBS services from you. And this applies to only a few of our CMAs, and those CMAs I have worked with directly to make sure that they have an internal policy that meets these standards. Next slide. Health Home Plus for SMI and AOT, there was no changes to this policy. It was an annual update. Some highlights from this policy is you want to make sure that if you are billing for a member at the Health Home Plus rate, that you have documentation in the record to bill at that rate. So if you are billing for a Health Home Plus member and on your HML, you're selecting a certain category to bill Health Home Plus for, you want to make sure that your supporting documentation is matching that category and it's uploaded into external documents. And also a reminder that members are Health Home Plus for 12 months. So you can bill at that Health Home Plus rate for 12 months. And at the annual determination, they will need to be redetermined as eligible to continue billing for another 12 months. The next updated policy we have is our adaptive and assistive equipment, environmental and vehicle modifications policy. This is specific to children enrolled in the HCBS waiver, and this is only specific to those youth who are applying for one of these three modifications. There has been some tip sheets that have been developed for these three services. So if you are going to be requesting one of these services for your youth, you have to issue the parent tip sheet, review the parent tip sheet with the parent, and you also need to document in the record that that has been reviewed with the family and or member. I sent out the HCBS toolkit today, and those three tip sheets are included in the updated toolkit. And as always, this is just a reminder that the health home care manager is responsible for gathering medical necessity for these requests. So prior to requesting one of these three modifications, you have to gather medical necessity from the provider. And that could be a physician's order, or it could simply just be something on letterhead from the physicians stating the medical necessity for the request. One of the newer, I don't want to say new, but newer things that the Department of Health has asked for is that they are receiving notification that you're going to be applying for one of these requests. It's right in the policy what you need to email the Department of Health, what email to send it to. It's basic demographics and then what the request is, but they're also now asking that you CC the health home in on these requests. So if you're going to request one of these services on behalf of your member, the first thing you need to do is discuss the parent tip sheet. Then you're going to make sure you gather medical necessity, and then you're going to email the Department of Health a notification and CC the email or CC the health home in on that email. This is a policy that I strongly recommend that if you want to request one of these services for your youth, that the first thing that you do as soon as this comes up in conversation is pull this policy up, review it, and then have the conversation with the family, because once you start movement on one of these steps, there are specific timeframes that you have to abide by. So you want to make sure that you know what you're doing as you head into one of these requests. And as always, you can always reach out to me if you have any questions. Next slide. Incidents and incident reporting. This policy was updated for some specific things around children. Restrictive interventions or restraints is now a reportable incident for all youth enrolled in health home, not just youth receiving HCBS. That was a recent update. Before, it was only for youth receiving HCBS services, but there was a clarification that is actually for all youth enrolled in health home. So that has been updated for that. As always, anytime you're made aware of an incident, you have 24 hours to report that incident. It doesn't have to be from when the incident occurred. It's only from when the health home care manager became aware of the incident. The other thing that they updated in this policy, and it wasn't just for children, it was kind of across the board, that they want to make sure that we are coordinating services with other entities if notification should be made. So that would be such as law enforcement or CPS, or if there was an incident that occurred at another facility that's either under OPWDD or OMH, that those proper notifications are occurring. Next slide. Initiating and maintaining the OPWDD LCED policy. So that's the level of care eligibility determination. This was just an annual review of this policy, so there was nothing updated. The one thing that I just wanted to point out is that if you have a youth that you are applying for OPWDD eligibility, or you're thinking about it, or you currently have one, you should probably review this policy. When we're audited, as we recently were, the Department of Health is really looking to make sure that if a health home care manager is pursuing a level of care, OPWDD eligibility on behalf of our member, or currently has one, is that the health home care manager is making sure that that eligibility stays active. It is an annual review of their eligibility. It's not an annual reassessment, but it is an annual review to maintain the active eligibility. And this is important, especially with our transitional age youth, because we want to make sure that we can transition them into adult services as needed. And we want to make sure that they're maintaining that eligibility and that we don't have to start all over if it should lapse. Next slide. So notice of determination and fair hearing policy. This was updated specifically again for children. The one thing that they added for kids is that notice of decision form, either enrollment or denial of enrollment into HCBS, so that DOH 5287, needs to be completed within 3 to 5 business days after the level of care has been completed. So once you complete the level of care and the UAS for that youth, whether they are eligible or ineligible, the health home care manager has 3 to 5 business days to issue the family the 5287. Prior to this policy, there were no timeframes around it. A couple other things in this policy just to be aware of is the 5236. So that's the denial of enrollment. So that's a member that you have an outreach and you are working with them to get them enrolled, but for whatever reason, they do not qualify for services, that you are issuing and documenting that 5236. With a 5236, like the 5287, if they are denied enrollment into health home, they have the right to a fair hearing. So that means they have the right to refute your decision not to either provide HCBS or not enroll them into health home. So you want to make sure that you have, especially when it comes to 5236, that you have documentation, concrete documentation as to why they do not meet eligibility. The 5234 is the notice for enrollment that is handed out to every member that we enroll in health home and also needs to be uploaded into the chart. That is letting the member know that they have been enrolled in our health home, what CMA, and contact information. The 5235 is the notice of disenrollment. This needs to be issued to any member that is not either in agreement with their disenrollment from health home or has not been notified that they will be disenrolled through Health Home. So recently we had that change that if you have a documented conversation with your member about disenrollment, and it is agreed upon, and that you're issuing a letter to them and letting them know that upon receipt of that letter and discharge that their consent to share information has ended. If that is all happening, you do not need to issue the 5235. However, if you cannot have that documented conversation with the family, then we need to be issuing the 5235, which also gives the member the right to a fair hearing. So that also means that they can refute the decision to be disenrolled, and they can pursue the overturning of that decision. So you want to make sure
Roberta,
that,
this
go
is
ahead.
Jackie Jackson. I just have a question about the 5236. The language you used was denial of enrollment. For the most part, when we get referrals from you folks, they're already deemed eligible for the program. So when you use denial, I don't understand how that works. Like, why would they be denied if they were already found eligible and you're assigning them to somebody?
So when we receive a referral through the health home, what we do is we basically check e-paces, we check MAP, we make sure that they have active Medicaid, and we don't really see any RE codes that would restrict them from enrollment. That's
Okay.
really all we do when we check eligibility. We're not cross-referencing their diagnoses or anything like that. So there could be an instance where you get a referral where the referent has marked that they have, chronic health conditions. But when you go to pull, let's say, a HICSNY or a psyches, or you speak to their provider, it comes out that those chronic conditions that they have aren't health home eligible conditions. So in an instance like that, they wouldn't be eligible for health home, because just because they have two chronic conditions, it doesn't make those two conditions health home eligible. That's just an example, but we check for basic eligibility. But once the CMA receives the referral, it's up to the CMA to make sure that they have documentation that proves them to be eligible.
Okay, so the 5234, the notice of enrollment, and you mentioned, if you're working with somebody with an outreach, I mean, when I speak with somebody on the phone and when I get the 5055, I usually enroll them at that point. So am I sending that letter, or is the care manager that gets assigned that person sending that letter?
That would be up to, that's an internal decision. So each CMA does it differently, whether it's the enrollment specialist or the care manager could be the one doing it. To my knowledge, everyone at your agency does have a 5235 in their record. So someone at your agency is doing that, and I'm assuming it's probably the care manager if it's not you.
Okay. So with the notice of enrollment, we've used that form before, because I'm not familiar with it.
Yes, that is a forum that has been in existence for probably 4 years, I want to say.
Okay.
It's not a new forum.
Hey, Jackie, it's Jared. I'll go over it with you.
Okay. Yeah, I just want to make sure I'm clear on with.
Yeah, you're
since
doing
I'm
everything.
outreach,
You're
my
everything.
role.
Yes. Okay.
Okay. All right. Thank
Yes.
you, Roberta.
Thank you, Jared.
Jessica.
Yes, your agency has those on file, so someone is doing them. So you guys are
Okay.
all set.
Okay.
There are a lot of 5200s out there, Jackie, for sure.
It's
Forms.
like there's so many forms. Just kind of speaking off the cuff, it just seems ridiculous to have a notice of enrollment. That's all I'm going to say. But we can keep going.
No, understood. Understood. It's part of the policy process that the state puts forward. I understand where you're coming from.
I love the forms. I get to memorize every single form and all the numbers. It's fun. So denial of enrollment. You want to make sure that if we're denying someone, we have documentation, and then if you're going to disenroll someone, for that 5235 that we have information, or we have documentation of that as well. So the 5287 notice of decision, and that is for enrollment or denial of enrollment for HCBS. So we talked about that a little bit earlier, that you now have 3 to 5 business days after completing the level of care to get that out. And also with that, there comes a fair hearing. That one's pretty cut and dry. You're either ineligible or you're eligible. If they come out ineligible and they'd like to refute it, they can, but that's a clear-cut assessment. And if they're not eligible, they're not eligible. And then lastly, we have the 5288, which is the discontinuance of the waiver. So that is for our HCBS youth. That has to be issued 10 days prior to disenrollment from the waiver. And also the 5235 notice of disenrollment has to be issued 10 days prior to disenrollment. So these are notice of decision forms, and they are all in this policy. And there also is a desk guide that helps you kind of tell you when and in what circumstance to use each form. And as always, with any of our forms, you want to make sure that they are all uploaded into your document section. You want to make sure that when you're completing them, they are completed in their entirety. We don't want to leave any check boxes unchecked, any lines not completed, because when we are audited, if it is not completed in its entirety, then we do not get credit for having the form there. And that 5287 notice of enrollment or denial of enrollment for HCBS, Heather, is only for children, not for adults. So that is only a children's form for HCBS, not an adult HCBS form. You're welcome.
So Jessica, I think you hit on something important, because there are so many forms, and to Jackie's point, it's a lot. The desk guide would be a good reference for folks if you haven't pulled it to utilize as just kind of a tickler, because it does have some explanation for each form and when to use it.
Yeah, it just seems, it really seems out of hand, but that's just my opinion. And once again, maybe I need to get a little bit of education behind why you would need all of this. It's
It is
overwhelming.
out of-
I mean,
It is out of hand, Jackie, so it's all out of hand.
yeah, it is. It's out of hand.
Well, I mean, we did lose a couple of, yes, but we did lose a couple of forms. They did get rid of some of them, ones that we weren't really using. So that was nice.
Oh my God.
But there's
I
a
can't
lot
even
of
believe that.
regulation.
Oh my God.
All right, so
Right.
everybody's
Next slide.
agreeing 5200s are excessive. Got it. We'll try to keep that desk guide, current for folks, just to help keep it so that there's some rhyme to the reason behind it. So thanks, Jess, for going through that. I know it's a lot, and I understand where folks are coming from. It's get your head spinning. Anything else for this slide, Jess?
Nope, we're all set. Okay, outreach and engagement. We got rid of a form. This was an annual review, nothing really new here. The only thing that we removed was we got rid of a form, and that was the 5059 opt-out form. So way back in the early days of Health Home, when we were doing outreach and someone opted out of services, we were supposed to be completing this 5059 and uploading it into the record. With a lot of feedback from Health Homes to the Department of Health, we were able to persuade them that this form was unnecessary and we didn't need it. So we were able to get rid of a form. So you do not need to complete this. And as with outreach, our outreach and engagement policy hasn't changed. It's just about the process of reaching out to our members, speaking to them about Health Home, trying to get them enrolled, kind of the process of that, some outreach ideas. This is nothing new. We've been doing this since for the past 10 years for outreach, but nothing really new here. This new palliative care counseling and support services and health home care management policy. This is the palliative care policy. It was called palliative care and bereavement services. The Department of Health, through the waiver amendment for children's HCBS, has changed the name of the service, therefore changing the name of the policy. The policy has not changed, but the name has changed. So the title of the policy has changed. And then throughout this policy, where you hear the service referred to, it is now referred to palliative care counseling and support services. This is not a service to date we have requested for any of our members. This, much like the AT, VMOD, and EMOD policy for this very small subset of children that we work with, I strongly encourage you, as soon as you feel that you may need this service, you pull this policy up and start reviewing it. Because much like that other service request, there are strict timelines around what needs to be done if you're requesting this service. So I strongly encourage the health home care manager and supervisor to pull this policy up, read it, and then start to request the service. And it's also very complicated. So if anybody needs to reach out to me for clarification or review it, or if you have any questions at any time, please contact me. Staffing qualifications policy. This was an annual review. There was no changes to the policy. All the same staffing qualifications apply for adults and children, just as they were before. And again, if you ever want to request a waiver for some of these staffing qualifications for adults or children, right in the policy, it tells you the request a waiver process. But otherwise, all of the qualifications have remained the same. The only thing I will touch on is recently all of our children's providers know that about, 6 months ago, we went through a children's qualification audit. The Department of Health has let us know that that will be done again. So I strongly encourage everybody to keep track of the training dates for their employees, because we probably will need those again sometime in 2023. On our website, there is a personnel checklist that kind of accompanies this policy. And it will go through, especially for children, because there are specific training requirements for children. It will chart out each required training, and then it'll allow you to track the date that those occurred. So when we are asked to provide those again for audit, that everyone has them. And I do have the spreadsheet from the last audit we did. So we will have that going into 2023's qualifications audit. Next slide. Transfers. This was an annual update. We did make one modification onto how transfers are occurring when they occur with another health home. Right now, everyone is sending other health home transfers to Courtney, and then Courtney's kind of working out the transfer with the other health home. What that is doing is it's not facilitating a good warm handoff between CMA to CMA at the new health home. So what we've decided is that the new process for transferring members to other health homes is that the health home care manager is going to complete the health home referral for the new health home. And if you know that you're transferring someone to a new health home, their referrals are right on their website. Courtney does have some of them saved. So if you need to know where a health, this person is moving to Schenectady County, who covers Schenectady County, Courtney can let you know which health home, and she probably has the referral form, or you can look that up on the Department of Health website. One of the things that we worked with through redesignation, and one of the things that was discovered in our audits, is the lack of warm handoffs in collaboration between CMA to CMA and CMA to health home transfers. So this new process will really allow that CMA to work directly with the new health home rather than going through Courtney to do so, and then really allow collaboration with that new health home and then potentially that new CMA assignment. And then much
Well, I
like
think
you're
part
gonna
of
send,
the issue, I'm sorry, Jessica, I think part of the issue was that is we don't know who we're contacting. So when we're trying to do a transfer to Albany County, well, who's the health home and who's the person? So everything got lost in the shuffle because nobody seemed to know. I don't think it was strictly a communication issue of not having the contact person.
right. So there is on the Department of Health website, and we can, when Travis sends out the slide deck, we can send out the link for that. But if you go
Okay.
right to the Department of Health's website for health homes, there is a little tab called Find a Health Home. And you click right on that. It's the website is it's like Health Homes Under Medicaid program. Again, we can send the link, but right at the top of that, there is a little button called Find a Health Home. And if you click on, thank you, Taylor. You can follow that. If you click directly on the map of New York State, it's broken down by county. If you click on this
Okay.
little map, it'll take you right to um any health home that covers that county, and it'll also indicate whether they serve adult or children and or both. So if you're transferring a child and or an adult, you can see what health home covers that area. Then once you click on that health home, the contact information and emails are right in there, and that'll take you directly to the health homes site where you can contact somebody. But if you
That's
ever
perfect.
go to start this process and you're not receiving communication from the new health home, then yes, you'll want to loop us in. Go ahead, Lori.
Well, and that's what I was just gonna clarify. So we contact a new health home and then wait for them to let us know who the new care managing agency is gonna be?
Yep. So their process should be exactly like ours because it is standardized across the state. Much like when we receive a referral, we let you know, like, hey, we got this referral, who is it from? And then we're communicating with the referral source. So you're gonna be sending a referral, and then you should be communicating directly with that health home. You should know who the CMA is, and you need to let them know, thank you, we're going to end date as of this date, and then you're going to facilitate, once you know that new CMA's name, you can facilitate a warm handoff of that case to that new CMA. And that warm handoff can look differently for everybody. It can just be a phone call. If you're very regionally located, it may look like an in-person meeting. It's really going to be case dependent on what that warm handoff looks like.
So is there gonna need to be, release form signed if we're gonna be talking to another health home member that doesn't have the
Yep, so you're gonna
information?
put, if you're gonna be transferring a member, you're just gonna update your current 5055, and you're just gonna put that new health home on there. Typically, when you're doing a referral, the referral to health home, you do not need consent for. So you can make a referral to the new health home without having a signed consent.
Right, I
Much
just
like
meant
people
sharing
can
the
refer to
information.
AHI without a signed consent.
I just wanted,
But
Jessica, I
then we
just
have
wanted to,
to, I'm
go
sorry.
ahead, Lori, you're fine.
So we don't need the consent to do the health home transfer, but then we'll wait for them to contact us to let us know who the CMA is. Then we will have the individual sign the 5055. The problem is sometimes is our folks have already moved.
In that instance, that'll all be documented right in the record. So if they've already moved and you're already lost with contact with them, you're just gonna do your due diligence to get that person handed off. Ideally, these are all going to be planned transfers, because if you have a member who is moving and says, oh, I want to transfer my services to Schenectady County, and then they move and then they fall off the face of the earth, it's not real at that point. It's not going to be a warm handoff transfer. You have no contact with that member. You're just going to do your due diligence to get that referral to that new health home so they can outreach that member. But at that point, you've already lost the opportunity for a warm handoff.
This is Jared. I guess I don't see where the issue is because every time I've done a transfer, I've always spoken to somebody in the county they were going to. It's otherwise you're not really doing your due diligence unless the person vanishes. So I'm not seeing where the issue is coming around.
The issue that was brought up during redesignation is that we had some CMAs who were not following the same process that you were. They were simply submitting the referral to the health home, and then the health home followed up with the new health home. And you guys, I say that in general, the CMAs were just discharging. And then there was nothing in the record after that new health home referral was sent to Courtney to process. The
Right.
chart just ended.
That
So there
was
was
my-
no documentation of that warm handoff and that facilitation to get that member to that new health home and new CMA. So the process that you're following, Jared, is accurate and correct, but that's not the process that each CMA was following.
That was one of the comments I was going to make, Lori, before I started to interrupt you. Sorry about that. Documentation was not either clear or it was lacking in the various charts that were pulled during redesignation to show any sort of transition of care or warm handoff as it relates to transfers. So, that was a strong parallel that coincided with process. There also wasn't documentation just to support that there was even any sort of warm handoff or any sort of connection to do a warm handoff in many instances. And then a couple of the charts that had some substance in there, it really wasn't enough to identify that it was a true communication effort for that warm handoff. So it's an area of improvement that as a network, we're looking to, talk through process through this policy as well. Documentation is important when we're looking at transfers and warm handoffs.
Thanks, Travis. So the process for transferring health home to health home is going to look a little bit different. So if anybody needs support with that, as always, please loop in the health home. You can reach out to Courtney. She can certainly be a support in this since she's the one that has been doing it on everyone's behalf. That was also noted, but then also internally when we have transfer CMA to CMA, that process is staying the same. You're still going to send those to Courtney as if you always have. The one thing that we do want to monitor is the handoff from CMA to CMA. So if I have a transfer to CMA B from CMA A, I want to make sure that CMA A is contacting the new CMA. You guys are having a discussion, potentially a three-way phone call for a warm handoff, potentially an in-person meeting, or at least an attempt to do all of those things, and then document that in the record. Again, this was an area improvement that the Department of Health wanted to see, is that when we transfer members, even within our health home, that to the greatest degree possible, we're attempting to have those warm handoffs and time-efficient warm handoffs. And again, this isn't going to be for everyone. Sometimes you have people who transfer from your agency under not so great circumstances. They could be, disgruntled for whatever reason and they want nothing to do with you. And you're just going to do your due diligence to follow up and make sure that the new CMA has everything that they need. And within our consent form, you can add the new CMA that they're transferring to, but also if it's going health home to health home, you can also reach out to one of us for support. So if you're transferring to CMA B and the member has decided they don't want a warm handoff, they don't want to talk to you ever again, they don't want to be a part of it, you can loop the health home in and we can certainly talk to that new CMA. And we've done this in the past, especially when we have transferred some members or we get a referral for a member who has some safety concerns. We always talk to that new CMA and kind of let them know and give them a heads up. So again, it's just to the best of your ability. And we understand that not every member that we transfer and that we move around is going to be compliant in this process. We just have to show in our records that we're doing our due diligence to do these warm handoffs.
And the health home, as always, loop us in if you're running into a difficult situation. I mean, we're here to support and help through that.
All right. Does anyone have any questions on policies we just reviewed or policies in general?
Do you want to poke your eyes out yet?
No, I mean, contrary to all of everybody, I actually love policy, so I don't mind it.
There's a big influx this time of year of policies, and I'm not sure why they were all written around the same time frame originally, but
I can tell you
but they
it's a
were. So,
conversation for after, but I do know.
so that's why we have such an influx currently, because our annual reviews are all coming up at the same time ultimately, and you'll see it drop off as the year goes on. Outside of DOH changes along the way, obviously, when they do a policy update, then we address. But in general, it's cyclic as far as quantity at one time.
All right.
Well, if any questions, please reach out. And again, the policies that we reviewed today, some are already updated on the website, others are in process. They're with our communications vendor who monitors our website and does all updates. So a handful of them will be up very shortly. Thank you, Jessica, for going through that. I know it was quite lengthy today.
All right, me again. Children's updates. I just wanted to let everyone know that there is a new HCBS audit tool. When I sent out the HCBS toolkit this morning, that was also included in there. That was updated based on our HCBS audit feedback, redesignation feedback, and then again, update to those HCBS policies. Yesterday I hosted a workflow HCBS refresher training. And then I will also be hosting one on the 30th. These are required for any current care manager carrying a HCBS youth, and or if you were assigned as a supervisor to one of these cases. So if you missed yesterday's session, there will be one on the 30th. Also upcoming, I am currently working on an HCBS plan of care training. It will be targeted for HCBS, but it is kind of a plan of care workflow training. So it will be useful to care managers, not even if you're just not serving HCBS, it'll kind of be helpful to everybody. So I'm currently working on that. I hope to have a date scheduled for that at the end of February. Then something that's not on here because it is hot off the press. Today I was made aware that there are some emails going out from the CANS Institute that the CANS has been updated. So you guys should be receiving those emails directly from the CANS Institute. I, however, did not receive an email and I received no notification from the Department of Health. The updated CANS is being updated just for some tweaks in language and the title of some of the domains and rating questions that they have. It's no changes to the real actual assessment. It was accompanied with, the email came with a short YouTube video that you could watch that went over some of the changes, really self-explanatory. If you did not receive that, much like I didn't receive it, one of my staff forwarded it to me. So if you'd like the link to that YouTube video, just email me and I can get that to you. But that is fresh of this morning. Another thing that has been worked on is the UAS. There is going to be a new feature in the UAS for completing the CANS, and that is the offline client automation. What that will allow for is remote access to the CANS assessment when there is no internet access or Wi-Fi available. This is something that was sent out to all HCS coordinators from each CMA. So on January 10th, each health commerce system coordinator should have received a notification memo letting them know that they need to identify IT staff at each of their organizations if they would like this feature. So not every CMA is going to need this feature. Not every health home care manager is going to need this feature, but it is available to CMAs and to health home care managers should this be something that you would like to have. The reason that it's not going to be blanket available to everybody is that it comes with some increased security risks because you're downloading something directly onto your laptop that will contain PHI that will then connect to a system at a later date. So this isn't going through the health home. It's something that the CMA will work directly with the UAS team on. So if you didn't receive or you have no awareness of this memo that came out on January 10th, I would reach out to whoever your HCS coordinator is and ask them if they received it.
There's
Does anyone
also,
have any questions? Oh, sorry. Go ahead, Travis.
I just wanted to reiterate, there's also an IT component with that security app that would have to be orchestrated through your organization. So just something to keep in mind if you're interested in taking that path.
All right, next slide. Okay, more on children's HCBS and audit results. What I did is we were given some information. This isn't all encompassing of the entire children's HCBS audit review tool, but this is some feedback that we were given from where our health home stands in comparison to where the state stands. So on the left-hand side of this chart, you'll see waiver year 21, 22, 2021, 19, 20. And then on the right-hand side, you'll see two columns. One column is going to be AHI's findings for 2022 and AHI's findings for 2021. The reason that I included all this information is I wanted everyone to be able to see where we stood in 2021 compared where we are in 21-22 for AHI, and then where we compare to the state. So on the first one, you'll see percent of participants' records reviewed that had a completed freedom of choice form. And in order to get credit for this form, the freedom of choice form needed to be in the record and it needed to be completed in its entirety. So as you can see in 2020, we received a score of 50%. And then in 21-22, we received a score of 60%. So what that shows is that we're not meeting the 80% threshold, but we are improving. And then if you look on the left-hand side, you can see that the overall state is actually declining and we're actually well above average compared to both years. Secondly, the percent of annual determinations level of care criteria were correctly applied. You can see that in 2021, we were at 57%, and then we jumped up to 90%, which is meeting the quality threshold as well as the entire state. So we're right kind of where we should be. Percent of initial level of care forms were completed and approved, required by the approved waiver. So that just basically says, was your LPHA completed correctly and was everything completed correctly within the UAS level of care? Now, as you can see, we're at 100%. We can't get any better than that. We showed improvement over both 2 years, and we have exceeded where the state is. The next one is participants reviewed with a plan of care that had adequate and appropriate needs and goals. So this is from their CANS assessment, for their comprehensive assessment, from their level of care. Did that plan of care reflect all of those needs and goals that they had. As you can see in 21-22, we had a 90%, so we improved. We are now meeting the thresholds. And as you can see, we are doing better than the state average. Next is percent of participants whose plan of care was updated, warranted by a change in the participants' needs. So as they audit our records and they read through our notes and they see a change in our members' needs, was the plan of care amended to reflect that? And as you can see in 21-22, 100% of the time, our hardworking care managers have amended their plan of care. So we are meeting the threshold, and we greatly improved on that from 2021, and we are above the state average. Next slide. Next, were participants receiving services according to their plan of care within 45 days. This is a complicated measure to meet. It is complicated because it doesn't necessarily mean that they have accessed and are receiving the HCBS service indicated in their plan of care. As you can see, we received a 0% for 21-22, and we dropped from the previous year, and we were on par with the state, but now we're much below. What this means is that, again, within 45 days of that HCBS level of care being completed, are our members receiving that service? It doesn't necessarily mean that they have to receive that service. As long as there is documented monthly communication with a provider about that referral, so you're communicating with that provider about where that youth is on their wait list, and as long as there's communication in there, we were given credit. What this is showing is that when they reviewed our record, none of our participants either were receiving that service or had adequate documentation to receive credit on this particular measure. So this is something that through refresher trainings, I have tried to emphasize that even if our members are not connected, we need to have monthly communication with those providers. The next measure was participants received service in the right amount for frequency, scope, and duration as specified in the plan of care. As you can see in 21-22, our score was NA because none of our members were connected to a service to even get frequency, scope, and duration to put them in a plan of care. But what you can see from this is the previous year we had a 66%, and as if you look to the left compared to the state, while we're not meeting the thresholds, we are above average for the state. So hopefully if we are remeasured on this in the next year, that hopefully we have shown improvement. Percent of participants who had an updated plan of care. So this is an annual plan of care. In 2021, we didn't have anybody who fell into that time frame. But as you can see, last year we had an 88%. So we are meeting the threshold. We're a little bit behind the state average, but as long as we're meeting the threshold, we're okay. Fee-for-service participants who have had a face-to-face contact with the health home care manager consistent with their acuity level. Are you meeting with your members face-to-face at least once a month if you're medium and high? That's what that was. That's what that is measuring. In 2021, that was not measured. It was a new measure for 21-22. And as you can see, we fell just below the threshold for meeting that requirement. And we're a little bit behind on the state. Our feedback to the state on this was we were under the public health emergency. So that explains why not everyone was at 100%. So hopefully that improves as we come out of the public health emergency. Next was percent of participants who received information on how to report abuse, neglect, exploitation, or an unexplained death, how to make an incident report. This goes back to that participants' rights and choice form that accompanies the freedom of choice form, that 5276. It is very important that when we enroll somebody in HCBS for children, that we are issuing and reviewing the freedom of choice form and that rights and responsibilities form, because that indicates that we have spoken to the family on how to report any number of these things. As you can see, we received 0% in 2021. So none of our members had a documented conversation that we reviewed this with the family. But as you can see, we made great improvement in 21, 22, now at 61%. We're not meeting the threshold, but I am very happy to see how far we have come. And you can see the state was very, very low in their percentages. They've also increased, and we are above where the state lies for those things. Next slide. Next is going to be the percent of participants that had a plan of care that was reviewed, that had appropriate strategies to address their health, safety, and risks. So this is going to be that safety and crisis plan. Is it accurate and updated? This is one of those things that I've been talking about and kind of stressing that anytime any of our members, whether in HCBS or just mainstream Children's Health Home, that they have that safety and crisis plan completed, and that anytime there is a safety or crisis concern, that we are referencing that safety and crisis plan and we're documenting that we've referenced it. So either that is shown through a note that says that you reviewed the plan with the family and no changes are needed at this time, or you have actually updated that safety and crisis plan because a modification was needed. In 2021, we were at 50%. And as you can see, we have increased our percentage. We're now at 76%. So we have shown improvement, which is the most important thing. We're not quite meeting the measure, but we have improved and we're on par with the rest of the state. The next is going to be that notice of decision form. Are our members receiving the notice of decision form? Is there documentation in the record that we have reviewed the notice of decision form, and was it completed in its entirety? Again, we don't get credit for any of these forms if they are not completed in their entirety. And unfortunately, you can see from the previous year, we have dropped a little in that. So I'm hoping that we do a little bit better. But as you can see across the state, this is also a struggle. So it's not just our health home that is falling a little bit behind in this measure. Lastly, it's going to be plans of care that were reviewed, that if there is a member that we're serving that is over the age of 14, there is goals in there that pertain to that youth's ability to live independently. So this is those transition age youth, that 14 above and then that 17 above youth. It's kind of those last two sections that are in your cans. And per policy for plan of care policy for our children, anybody over the age of 14 does have to have these goals in their plan of care. And this is something that they're measuring in the HCBS waiver. As you can see in the previous year, this is not something that we met. None of our members have it. But then you can see that we show great improvement last year, where now 66% of our members have it. So we're just slightly behind the state on that. But as long as we show improvement, I am happy with that. And our next HCBS audit is scheduled to begin, I believe, in April of this year. We have not received the schedule yet, but they said that they're going to start April-ish. And last time we were one of the first to go. So I believe we will be one of the first that are scheduled for this year. Does anybody have any questions on anything that I just went over?
Thank you for doing the crosswalk, Jessica, in comparison to the state.
That was a lot of me talking.
Yes, this is Jessica Day.
Yeah, I did not mean it to be Jessica's health home office hours. All right. Well, if you guys have any questions at any time, or you want to review on anything that is children's HCBS, please let me know, and I will be happy to do so. And now it's my time to be off. I'm done.
Thank you, Jessica. I appreciate all those updates. All right, so just want to do a quick touch on Data Den rollout. We're 2/3 of the way through all of our organizations in the network. We're slated to be done with our rollout by the end of the first week of February. So we're excited about that. So far, so good with feedback. I know there's been some initial issues that we've been working with our vendor who's behind the scenes on the platform currently. So we do appreciate the patience that we've had as folks that have run into that issue as we've been getting you on. But once folks are on and in the platform, the feedback's been pretty good, and we're excited about that. So big message we want is to continue to encourage folks to reach out with any ideas or suggestions for improving the platform. Once we get everybody rolled out, as Taylor's been saying, through the demonstrations for each organization, we're looking to do a little more beautification in the platform, make it a little more user friendly for folks. So any suggestions along the way, we welcome. And the comprehensive chart audit tool for children's and adults. So the health homes updated those tools. We're piloting them the first couple months of the year through our comprehensive chart audits. We just did an adult chart audit recently, and we actually made an addition to the tool. But the reason I bring it up is they're going to be available on the website in the very near future once we finalize those drafts. And be available for everyone to use if you'd like. Just note that they are what we are going to be using, just like the tools that are on there now for folks to access on the website as we audit our comprehensive audit reviews for each organization. So if you have an interest in what we're looking to look at when we do those chart reviews, those would be the tools that we use. So the updated versions will be coming out shortly. And the changes that are enhancements to these tools are primarily due to redesignation. I don't want to say requirements, but encouragement from DOH and the other auditing parties during redesignation. So we thought the best way to put those recommendations forward were to include them in the audit tools themselves to ensure that we were capturing that as we were working in the charts. Some more to come there shortly. I mentioned early on today, before Jessica took the stage for a while, about the quality assurance performance improvement policy. We're in the very final stages of updating that. And next month at the office hours, we're going to take the time to walk through that. One of the reasons we're kicking it to next month is because we had, as you saw, a number of policy reviews this month. So we thought this might get lost in the mix if we added one more in there. But these are the areas of the policy that are really going to be incorporated that weren't necessarily there before, just to give folks a heads up what we'll be touching on as we get into that policy next month and moving forward. And a couple of the things that we'll get in more depth on when we meet on it are really going to be around that corrective action process as a tiered process for any quality concerns working with an organization. It's not something we've had spelled out in the past. We're going to have that spelled out in the policy moving forward once we implement. So again, we'll take the time to talk through that, but we're going to incorporate tools such as Data Den. That's one of the reasons we're rolling it out as a tool for the network. So that's going to be a tool identified in the policy. All the work around the quality notebook that we put forth over the past year, reporting thresholds for Health Home Plus standards, office hours, organizational attendance, and some other components to the policy that we wanted to enhance on. So more to come there, but just to give folks a heads up, we will be reaching out to agency administration prior to our office hours rollout, just to make folks aware that we are going to be implementing this policy with all these changes. And that is a courtesy due to the fact that there are going to be so many changes to this policy that we wanted to make sure that agency administrators were aware of that because it impacts health home care management. So more to come there as well. So next month, we'll get into that. I wanted to touch quickly that Shelters of Saratoga is to the point now where they're hiring a staff for health home care management. once they have that staff person hired, we're going to be doing our onboarding training in person, which we're excited about doing because we haven't been able to do that in some time due to COVID. And once they have that in-person training with the Health Home team, they're going to be live. So we're hoping that's going to be happening in February. So we want to welcome them moving forward. They will start to attend the office hours moving forward. And they would be organization number 25 in our network. So we're excited about that. And then PHQ-9, just wanted to remind folks, well, first off, we're working with NetSmart because the link in the comprehensive assessment to get to the PHQ-9 for the depression screening is not working currently. And we're in communication with NetSmart to get that link working again in the new comprehensive assessment tool. And in the interim, we want to make sure folks are completing those PHQ-9s. And you can get to that by going to the assessments tab and dropping down, and PHQ-9 is an option. So I just wanted folks who may not have been aware how to get to the PHQ-9 assessment. This is how you get there in NetSmart. It is part of that final comprehensive assessment. That's why it's a link that should be working within the assessment that is part of that in the process. So we just wanted folks to be reminded of that. And it's also something as we roll out data, then that is one of the reports that people will be able to see in real time, if you will, of where those assessments stand. So we will definitely let the network know once NetSmart's able to get that link active again in the comprehensive assessment. Delay reason 3 code. This is something that as of January 1st, we were notified, all health homes were notified through DOH that this administrative delay code, which is something that the lead would utilize for billing purposes for anything that would be 90 days or over for claim submission, that is no longer an option unless otherwise indicated by the Department of Health approval. So something that came through the pike, we had to start implementing that for anything January 1st or after of this year. Not utilizing that, it's not an option, so we can't utilize it. But I just wanted to make sure as a network, we were all aware as organizations working for billing purposes. The intent is that 90-day window to submit claims should be the window within that claims are submitted. So heads up on that.
Travis, what if you have a corrected claim based on a review?
Our interpretation at this point, Lori, is anything from January 1st of this year moving forward. This is the way that we're understanding this. So if it's a prior claim, prior to this January date, I don't think this would apply at that point because you would be resubmitting based on the time frame that you initially submitted. But moving forward, our understanding is this 90 days from January 1st moving forward, that this administrative delay code cannot be used.
Okay.
Is that helpful?
I'm not sure. I'll look later.
Okay. Yeah, again, if you have certain circumstances, let us know and we'll definitely look in and inquire on things if we're not sure ourselves. But this was one of those last minute, they dropped it at the very end of the year across the state to let health homes know that this change was happening. And then the links, just if you have more information that you'd like to know around the billing guidelines, eMedNI, et cetera. Healthcare workforce bonus. This was sent out to the network a couple weeks back. I just wanted to throw it on here as a reminder that New York State did add in the health home care management title as an applicable title for the healthcare workforce bonus. The link to that expansion notice is here. I urge organizations or the appropriate entities at your organization to go to that link because the agency has to be the one to apply for those bonuses, if you will. At February 1st is supposed to be the opening date, and then there'll be a 30-day open window for submissions for this time frame as of February 1. So good news, but you have a window of 30 days at this point as of February 1st. So encourage folks that are the appropriate parties at your organization to look into this and look to secure those bonuses for those that are applicable. And then public health emergency. So January 11th, the federal government extended the public health emergency to April 11th of this year. It was stated again by the federal government that they would give a 60-day notice prior to the public health emergency ending. So that's supposed to be coming through 60 days out. One of the things DOH indicated to us last week on a call to health homes and MCOs that were involved were the following: that the face-to-face requirement enacted via policy is going to go back into effect as required for those populations that require it. Wet and electronic signatures are going to remain allowable. And then there's discussion around a possible extension of the plan of care due date timeline requirement. It's under discussion right now about extending it potentially from where it stands now. So more to come on that, but it is something that, right now we're following the 60 days. There is talk about maybe going 90 or maybe even further, but 90 seems to be the number. But don't quote me on that because it hasn't come officially through. So, but as we learn more, we'll let folks know. But those were the three key things that were mentioned by Health Home through DOH last week. And so at this point, it stands that April 11th of this year is supposed to be when the public health emergency ends for the federal emergency waiver. And that's all we had. Again, thank you to Jessica for your long, important presentation today on policy and HCBS updates and children's updates. Thank you. Anybody have any questions or anything they wanted to talk about otherwise that we haven't mentioned? No? Well, you know where we're at if you do. And I want to thank everybody for attending today. And as always, thank you for everything you do out there. And we'll be in touch soon. Have a great afternoon, everybody.
Thanks, guys. Have a great day.